Hey guys, it's Dean. Welcome back to the Better Man podcast. Today I am joined by Lance Frank, who is a pelvic floor physical therapist specialist, which is a title I just botched, but he will be able to give you the official title shortly. And he is going to be talking with us about pelvic floor and men's sexual wellness issues in general. So this is going to be a really cool episode. Lance, thank you for being here.
Thanks for having me. I'm excited to talk about it.
Yes, and if you could clarify your title and your education, all that stuff for us, so I don't sound silly at the beginning.
That's okay. I am a physical therapist. I have my doctorate in physical therapy, and I have a specialty in pelvic floor dysfunction. So I'm a pelvic health physical therapist.
So my wife is a physical therapist. She's a PT, DPT, OT, OCS, and I'm curious because from my understanding, pelvic floor specialist, the physical therapist who specialize in pelvic floor is not super common. So what kind of extra training did you go through for that, or what's unique about being someone who specializes in pelvic floor health?
Yeah. So I, to be a pelvic floor PT, there's a series of continuing education certification courses that you have to take. And if you would like, kind of like your wife, if she's a orthopedic clinical specialist, she took her OCS and passed passed that certification exam.
Hmm.
To be a pelvic floor PT, there is no official certification exam from the American Physical Therapy Association, the ABTA, like the OCS, or if you're a neurological clinical specialist, you have an NCS or a pediatric. Those are recognized certification exams by the APTA. Currently, there isn't one for pelvic health, but
Mm.
there are other governing bodies, if you want to call it that. Specifically, Herman and Wallace is the one that I've taken all my training through. They have a certification exam that has been immensely, tested, and that's what I'm currently working towards. So their certification is pelvic rehabilitation practitioner certification, PRPC.
Hmm.
So I'm planning to take that in December.
Okay, cool. So what is the scope of your work as someone who specializes in pelvic floor?
Um, I like to tell all my patients, everything above the knees and below the rib cage is kind of my specialty. So
Okay.
peeing, pooping, issues with having sex, any kind of general pain complaints in that region,
Hmm.
that's my forte.
Okay. And let's actually clarify what is the pelvic floor? Because I think there's a lot of misconceptions about, the pelvic floor is not your entire core area, or, what would you call your pelvic floor?
The pelvic floor is a group of muscles that sit in your pelvis, and they're the main muscle groups responsible from a musculoskeletal standpoint. They're the main muscles responsible for our ability to urinate, defecate, and have sex. And if somebody has a uterus, reproduce. So, and childbirth. But
Hmm.
from a male perspective, peeing, pooping, and getting an erection,
Hmm.
ejaculation, all of those roles are primarily driven by the muscles of the pelvic floor.
Are these muscles, are your pelvic floor muscles, is that something that is generally exercised in, like typical exercise, or is it something that, you might have to train specifically?
It depends. um,
Hmm.
everybody knows, well, most people know whenever you say, a Kegel, most people know what a Kegel is.
Hmm.
And whenever people think of pelvic floor PT, that's the most common question I get. And they're like, so you just teach people to do Kegels all day? I'm like, I mean, no, yes and no. But with regular exercise, the pelvic floor is best friends with our abdominal wall, the rectus abdominis, and the
Hmm.
deepest layer of the abdomen, the transverse abdominis.
Hmm.
The TA and the pelvic floor are best friends. And so it's physically impossible to engage your core and not engage your pelvic floor. So anytime you're doing a crunch, anytime you're doing a sit up, anytime you're doing a plank, your pelvic floor is inherently turned on. And so
Hmm.
whenever I'm trying to teach functional strengthening for the pelvic floor, it involves a lot of the traditional like mindset of what a core exercise regimen would be.
Hmm.
Um, but if somebody is having a lot of incontinence and they just have zero idea how to engage their pelvic floor at all, well, that's when I'm directly targeting and going after the pelvic floor muscles with exercises similar to a Kegel.
So these muscles are basically they're agonist muscles, or they work in synergy.
Yep.
Can
You physically cannot contract your pelvic floor and not contract your abdominal wall. They with those two contractions happen together simultaneously.
That is really interesting because I actually heard like the exact opposite from somebody else like a few months ago. So I'm not going to say who it was. I'm just going to assume that you are correct. Um, but that's interesting. That's news. So you cannot isolate your pelvic floor and just like use your pelvic floor on its own.
You, I mean, you can bias the pelvic floor, but you're
Okay.
never going to not contract your abs at the same time.
Okay. And I'm doing this right now. I'm doing Kegels and I'm like thinking like, okay, are my abs working as I'm doing this?
If you feel, and so it's not your six pack muscle, it's not the rectus abdominis, it's the
Hmm.
deepest layer, your TA, your transverse abdominis.
Hmm.
And so if I'm having a if people are having a hard time getting a pelvic floor contraction,
Hmm.
I'll have them focus on engaging their TA because
What's
that,
your favorite exercise for engaging TA and transverse abdominis?
I mean, the most basic one where I always start is just having people lay on their back with their feet up, with their knees up towards the ceiling in this hook lying position, and
Yeah.
just have them focus on engaging their core. So if people are listening and if you want to do this too, you can put your two fingers on the insides of your hip bones,
Hmm.
just inside the hip bones there. And if you think about, I there are a lot of a lot of cues that I can give people, but the most common one is try to flatten your back into the table, or try to turn on your abs as if you're trying to bring your belly button towards your spine. And
Hmm.
so it's, or a lot of my guys resonate the most where, think about somebody's about to punch you right in the stomach. Most
Yeah.
people would want to do a little bit of a brace. And
Hmm.
so if people are laying on the table, and I don't actually hit my patients, but I go, think about if I'm going to hit you in the stomach, what would
Yeah.
you do? Turn your abs on. And most people know how to do that. And
Yeah.
so
Instinctively.
it's not, excuse me, it's not a really intense brace or a bear down. People aren't like, you know, straining, but it's
Hmm.
once they feel what should be happening in their abs, and then I'm like, okay, now give me like 50% of that. And
Mm.
once they get that, then we start to incorporate that contraction into other positions, whether that's hands and knees or standing or in a squat. Um,
Hmm.
because if people, especially my guys that have just gone through, a prostatectomy after prostate cancer, if they've had their prostate removed,
Hmm.
a lot of guys have a lot of issues with incontinence. And so if those muscles are just so weak, and they have a hard time even feeling a contraction down there, well,
Hmm.
I normally with those guys start with just a lot of core strength and development.
Hmm. Got it. That's really useful information. Um, Thank you.
You're welcome.
S- So, um, what are some of the let's just get a really broad scope here. What are some of the the biggest problems when it comes to men for pelvic floor?
I would say, by and large, the most common diagnosis that I see is a condition called prostatitis, or AKA chronic pelvic pain syndrome. And it just, all that generally means is you have a generalized pain in your perineum, or in your pelvic floor, the space
Hmm.
between your testicles and the anus. Um,
Hmm.
prostatitis
So
is a,
that's the pelvic floor is specifically that area right under.
yeah,
Yeah.
the space between the testicles and the anus.
Hmm.
Throughout this interview, you'll hear me say words like perineum, pelvic floor, pelvic girdle, pelvic
Hmm.
diaphragm. They all mean basically the same thing. And
Hmm.
it's the space between the testicles and the anus. You've got muscles on the outside that you can touch, but you've also got muscles on the inside that you can't necessarily touch unless you've
Mm.
got a finger up your butt, which
Okay.
is one of the ways that I assess somebody's pelvic floor internally with an internal exam. Um, but yeah, the collectively, the perineum, or the pelvic floor, is the space between the testicles and the anus.
Hmm. Okay. So what are some of those the most common problem you
Oh,
mentioned
right.
is that pain. What about some other ones? Sorry, that was me interrupting and
No,
I
that's okay.
apologize because I'm like I'm just interrupting you to
Yeah.
ask like questions that are like, oh, well, what about this? I'm curious
No,
about this. Like, what about this? So,
no, it's great.
yeah.
Yeah, common conditions that I see a lot of. So, like I said, prostatitis, chronic pelvic pain syndrome. I see a lot of testicular pain that a lot of times patients think is their testicle actually hurting,
Hmm.
but it's a lot of times referred pain into the testicle from the pelvic floor muscles or the surrounding hip muscles.
Oh man.
It's these guys have been bounced around from urologists to primary care to oncologists, and nobody can figure out where their testicle pain's coming from. And a lot of times, if there's no like infection or if there's no mass, if there's no like medical reason, usually it's a musculoskeletal issue and it's a pelvic floor problem. So I see a lot
Wow.
of testicular pain.
I mean,
Or,
I didn't think about that. Like I think about like, trap tightness and like, radiating to your neck. But like I did not think about like pelvic floor tightness radiating to one of your balls.
yep,
That sucks.
it does suck. But among the different conditions that I treat, it's it sucks because a lot of guys. I have a guy now that I've been working with for 3 weeks that has had left-sided testicular pain for 6 years that nobody's been able to figure out, and we've reduced his pain almost entirely in 3 weeks just by addressing the pelvic floor. And so it's a shitty condition to have because a
Hmm.
lot of times it takes a long time to get to somebody like me, but it's I would say the easiest conditions to treat once you get it actually somebody that knows what they're looking for.
And so there are no muscles in the penis itself or in your testicles, but pain can radiate to your testicles.
There's no muscle in the shaft of your penis, in
Hmm.
the, well, I guess I should say, in the external shaft of your penis, the
Hmm.
part that hangs. There's no muscle in that. There are also no muscles directly in the testicle, and so most of the time, the muscles that refer into the testicle. I wish I could share my screen, and I'm a visual learner, and so I have
Hmm.
an anatomy app that I love because it's great. It's a 3D model, but anyways, the adjust, if people are listening at home or if you want to do this too, think about touching that perineum, that space between the testicles and the anus, and if you slide your fingers upwards towards the shaft of your penis,
Hmm.
that about inch to 2 inches where that forms that almost like a bulb down
Hmm.
there, it's called your bulbospongiosis, and that muscle is the primary muscle that allows us to ejaculate. So whenever
Hmm.
we have orgasms, it has like 10 to 20 rapid contractions that eject semen out of the penis.
Hmm.
There's another one and that pretty close to that same spot. It's called your ischiocavernosus, and its main job is allows us to get an erection.
Hmm.
And so there's no muscles in the external part of the penis where it hangs, but that the very base where it attaches into the perineum, that's where those two muscles exist. And those two muscles often refer into the testicle whenever there's a trigger point or overactivity in them.
So are there exercises that, now I'm like thinking for myself, are there exercises that like specifically strengthen your ejaculation muscles, or there are?
I mean, it's essentially all the same exercise. It's all like Kegels. I hate calling them Kegels because
Hmm.
it
It's
everybody's
so
just like,
general.
it's so general, and a lot of people don't know what they're doing. Like I
Hmm.
have a lot of patients that if I just ask them like, show me what you think a Kegel is, people will be squeezing their butt cheeks together, or they'll be like
Mm.
squeezing their inner thighs together, or they'll just be really tightening their abs. Like a lot of my patients have no idea what their pelvic floor is, and whenever
Hmm.
they think that they're doing a Kegel, they're absolutely not. And so a pelvic floor contraction is usually what I call it. If I want you to do a pelvic floor contraction, think about the cues that are mostly going to target the bulbo and the ischio are make your penis jump or try to make your penis shorter.
Mm.
Um, some that Another cue that some people don't always get is think about trying to lift your testicles up into your abdomen, lift your nuts to your guts. Those
Mm.
also engage the more anterior or the penile muscles, ischio and bulbo spongiosis.
Okay. No, I'll be honest. I'm like practicing this as you're saying this because I'm curious, and like I actually felt a difference between the make your penis jump and like and the make your penis shorter. Are those two different muscles?
It Yes and no.
Okay. Are they
So
muscle? Yeah, go ahead.
Well, think about, we've got fast twitch and slow twitch muscle fibers. And there are muscle groups that are fast twitch that are more like reactive, like they are quicker to turn on. And then you've got more endurance or stamina muscles that are more slow twitch.
Hmm.
The same principle can be true in the pelvic floor and specifically for the penis. Ejaculations are quick, they're rapid fire. So think about the cue, make your penis jump, is mostly for bulbospongiosis.
Hmm.
Ischiocavernosis, erections, we have to be able to not only get an erection, but maintain that erection. So it's more of an endurance exercise. And so the cue, try to lift your testicles up off the table or lift them up off the floor and try to make the head of your penis or make your penis shorter. Those are, I'll have people do those contractions, but then I'll tell them, okay, now do that contraction and hold it. I want you to hold it for as long as you can.
Hmm.
That's more of an endurance. So it depends on what people are coming in for and which exercise that I'm giving them, if that makes sense.
Yes. Okay, and I do want to ask specifically about the most common problems for men in their 50s and 60s, because that's the majority of the people I think listening to this podcast and people in Manful Yoga are in that age demographic. However, I am selfish and I want to ask a question for people who don't have any acute issues, which I don't know. Actually, we'll get into talking about just how many issues, just what percentage of men do have acute issues with pelvic floor health, because I think that's understated. But if you have relatively no noticeable acute issues, you have decent sex life or decent erection strength, decent ejaculation, can you, by doing these types of exercises on a regular basis, are you going to have like, is your is your sex life going to like, or the strength or the pleasure of your erections or your ejaculations, is it going to go up like can we train this to the point where you're like all of a sudden sex is like three times as good as it was? Or are you going to are you going to notice like more like marginal like maybe 20 to 25%? Or has this even been quantified? Is this something that even is like, or is it just like you can come or you can't?
um, I'm going to have to break that down a little
Okay.
bit into separate answers.
All right.
And the reason being is that, first, there's no, like, to my knowledge, I don't know that there's ever been a study that's looked at that. Can pelvic floor therapy or can pelvic floor specific exercises actually enhance the qualitative measure of increased pleasure? I don't know that that's ever been looked at. I mean, I'm
Thank
sure it
you. Thank you
has.
for saying that in a way that was medically acceptable.
Yeah.
Yeah.
um, I don't know that that's ever been looked at. In my brain, and whenever I'm thinking of rehabbing patients, and the reason I wanted to break this up is because while we're talking about what so far everything that we've talked about is more of a strengthening based mindset for more of an underactive pelvic floor or a low functioning pelvic floor. By and large, the majority of my patients had the exact opposite problem. Their pelvic floor is doing too much. And so
Mm,
I
interesting.
it's rare that I these give them these strengthening exercises. A lot of the stuff,
And what age are those guys?
I would say those are usually my younger guys, the
Okay.
the 20, 30, 40s.
Hmm.
Generally, once we get into the older kind of age ranges, those are the more, I would say, I don't want to say underactive, but less active patient or pelvic um, activity patients. I botched that. But
Hmm.
in pelvic floor therapy, patients typically fall into one of two categories. It's either an underactive pelvic floor or an overactive pelvic floor, a hypotonic pelvic floor or a hypertonic pelvic floor. Most of the patients that I see on a day-to-day basis fall into the overactive or the hypertonic pelvic floor. And so those are the guys that I'm the 20 to 40-ish age range that I'm not giving them a Kegel, not anytime early in their therapy, maybe even ever, because they are the fit, the super tense, the type A. I always joke, these are my tight ass patients. These are the patients that just never ever ever relax their pelvic floor. And so the last
But
thing I want them to do is to do a Kegel, because it's just like it's only going to make all of their problems worse, especially if there's pain.
mm,
But to your question about the older, demographic, 50, 60, 70s, those are the guys where, yeah, I might want them to be doing some targeted strengthening exercises depending on what they're coming in for. Usually it's ED, usually it's some sort of incontinence related issue, whether that's fecal or urinary incontinence. That demographic is usually doing a little bit more strengthening. And so, yes, targeted pelvic floor contractions, but also all the core, upregulation exercises, planks, um, Pallof presses, those types of over entire core based exercises.
Hmm. Wow. Okay. Well, that's cool. On one hand, that's cool because it validates, the kind of the a lot of the content that I've created with core strengthening having to do with improved, sexual health, which to my understanding and everything that I knew about it, like, okay, this makes sense. This helps, but it's cool to hear that. Oh, it does actually, from somebody like you. So, what are some other, I think we covered a lot of the big ones. We talked about, sexual dysfunction. But it sounds like those guys who are 20s, 30s, are they people who tend to have more premature ejaculation, or they just have, okay. So can we talk about the difference between, like, what is premature ejaculation, by the way?
Well, medically, premature ejaculation is defined as an ejaculation that occurs prematurely or
Hmm.
earlier than one would like. Um,
Yeah.
Usually, it's within a couple. It's rare that it's over a couple of minutes. Usually, it's within a couple seconds.
Hmm.
And so,
It's
if
that definition is interesting because I remember I made a video on premature ejaculation once, and it's all about controlling your breathing. It's about slowing down, controlling your breathing, controlling your body with that. But one guy left a comment and he said, maybe we just need to lower our expectation of what our ejaculation should be. Like, maybe it's you're doing this all wrong. Like, you're making people feel bad about coming too quickly. I'm like, I don't know if that's the way to look at it. But sure.
no,
It
you
was
know,
it was just a very unique response that I thought
right.
I should bring up.
There's a difference between intentionally dragging it out or intentionally, delaying ejaculation
Hmm.
and not having the ability to delay ejaculation, like not having control over your pelvic floor, control of your penis enough to where it's just happening. Like I evaluated a guy last week who he was like on a good day, 2 minutes,
Hmm.
on a bad day, 20 seconds. Like
Mm.
that was his spectrum. And he was like, if I'm having sex with my wife and if I go like 5 or 6 rounds, well then yeah, by the last round it's gonna be like 15 minutes. And he's like, but how many times have you been able to have sex 5 times in a row, back to back to back? He's like, I can do it, but it is
What?
right.
Like, what world is this guy living in where
Right.
that's normal? It's like, oh well, yeah, yesterday was like an average day, just 5 times in
Yeah.
2 hours. Like, oh,
Right. I was like,
okay.
wow, okay. But
That's insane.
so from a pelvic floor standpoint, if there's no like premature ejaculation, I don't want to put plant seeds in anybody's heads, but there are medical reasons as to why people can have premature ejaculation. If there's like a spinal
Hmm.
cord issue, if there's like a brainstem issue, those are very, 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 very rare.
Hmm.
The typically kind of what you were talking about earlier, there's a breathing. People don't have control over their breath and they don't have control over their pelvic floor. And so the way that we as men or people with penises ejaculate and have orgasms is the pelvic floor has 10 to 20 rapid, really strong contractions that
Hmm.
initiate this physiological process in our spinal cord that sends it to the brain that it's like, all right, it's time to come. When
Hmm.
those contractions happen, that's whenever we ejaculate. And so the threshold, when we're talking about underactive versus overactive pelvic floors, there's a certain threshold in which the pelvic floor has to contract in order to initiate that orgasm.
Hmm.
And if you think of your scale, think of your pelvic floor on a scale of 0 to 10.
Hmm.
If the threshold to get to an orgasm is an 8 out of 10 in terms of strength, an 8 out of 10 contraction, and you live your life every single day, just your baseline is a 6 or a 7,
Mm.
that window to get to that threshold is going to take, a lot less time than somebody who lives their day-to-day life in a 2 or a 3 out of 10
Mm-hmm.
threshold. And so when I'm working with patients with an overactive pelvic floor or premature ejaculation, I'm trying to get them into more their body, their minds, their nervous system into more of a down regulated state,
Mm.
which, before you, I absolutely love what you're doing with all of these guys. But before I knew you and before I knew of your account, Manflow Yoga, a lot of what I gave people already was very meditative, yoga based
Mm.
flexibility movements. Because, and we talked about this in our call a few weeks ago, like
Mm-hmm.
yoga and pelvic floor PT, especially with the overactive pelvic floor, is such a beautiful marriage because a lot of my movements and a lot of my exercises I borrow from yoga and yoga
Mm-hmm.
practices. Um, the pelvic floor and the diaphragm, the muscle that helps us breathe, is another best friend group. So we talked about the TA and the pelvic floor earlier. The diaphragm and the pelvic floor are also best friends. And if things are working functionally and optimally, they should be working in tandem. When we take a big breath in, when the lungs inflate, the diaphragm drops down, it pushes all of that pressure on top of the pelvic floor. And if the pelvic floor is working appropriately and correctly the way it should lengthen and relax to accommodate all of that pressure, kind of like a hammock or a sling or a
Mm-hmm.
trampoline. Whenever we exhale, the lungs deflate, the diaphragm rises, everything in our abdomen gently shifts upwards, and the pelvic floor should, if it's working correctly, contract and pull up and in. So there's this
Mm-hmm.
piston mechanism between the diaphragm and the pelvic floor. They play catch with one another with the internal pressure. And so whenever people have an overactive pelvic floor, they're clenching all the time.
Mm-hmm.
Usually, every time they take a big breath in, the diaphragms or the pelvic floor either doesn't move or it does the opposite of what normally happens. It relaxes when it should contract and contracts when it should relax.
Mm.
When I'm evaluating people on the table and I have them do all I do, which if you're not in the exam room and you don't know what pelvic floor PT and you don't know what I'm looking for, it sounds kind of strange. But I have people lay on the table and I have them lay in a butterfly position and I'm literally looking in between their legs. I'm lifting up the scrotum if it's in my way because I want to see what their perineum, their pelvic floor is doing.
Mm-hmm.
Because when people take a big breath in, if you think about filling up a balloon with air, how the balloon kind of expands outward,
Mm-hmm.
that's what should be happening with the space between the testicles and the anus. And so I have people take a big breath in and just observe what is happening down there. And a lot of times there's either no movement or it contracts when it should relax. Like it kind of puckers up and in when it should expand outwards.
Mm.
And so when we're talking about premature ejaculation and overactive pelvic floors, we talked about that threshold in which it takes to achieve an orgasm or ejaculate. If people can learn to control their breath, by like the most common thing that I see with people do that have premature ejaculation is hold their breath. They'll hold their breath and they'll tense their abs, which, as we know, the diaphragm and the TA are, if you're contracting those two, the pelvic floor is going to be locked up.
Mm-hmm.
And so a lot of what I do with people is teach them how to breathe, teach them how to do a diaphragmatic breath and drop their pelvic floor at the same time. If I can get patients to sync up their diaphragm with their pelvic floor and learn to relax it, usually most of the time I have success with patients being able to extend or prolong their ejaculation or their orgasm.
Mm. Wow, that's so cool. So, in the if you do just let's say you just lay on your back and you do a normal diaphragmatic breath, or like what would be considered proper technique for a diaphragmatic breath. And I've got some videos on this, by the way. I have a blog. If you're listening to this right now and you want to, or I think we already talked about, the diaphragmatic breathing here too, but I do have a blog on this. Go check it out on the website if you need a more in-depth tutorial of the diaphragmatic breathing. But if you do that, is that if you do that properly, is that just going to do what your pelvic floor naturally should be doing? Like if you have a proper diaphragmatic breath, does that mean that your pelvic floor should, be doing what it's supposed to do?
Not always.
Hmm. And so, and that question leads me to what extent is this a physical issue, and kind of to what extent is this a non-physical issue? Like to what extent stress and anxiety, or unusually high levels of that, or you know, what else is going on here?
I would say when we're talking about overactive pelvic floors, the most common question I get whenever I'm talking and going through all this education with patients is like, why is this happening to me? Why me? What am I doing that, this happened? And I would say time and time again, the most common cause is stress, anxiety, depression. That like we live in a very high stress environment, a very high stress environment, society. And when patients don't have any productive or constructive outlet to rid that in their day-to-day life, we hold tension and stress. A lot of people hold it in a lot of different ways. Some people hold it in their shoulders with their upper traps. Some people hold it in their hands or in their feet. Some people, most of my patients, hold theirs in their pelvic floor. And so, kind of what I was saying earlier when I joke that like my overactive pelvic floor patients are the tight asses. They are the high strung, the stressed, the anxious, the depressed. There's a huge psychosocial aspect to pelvic floor dysfunction. And to answer your question about diaphragmatic breathing, you could do diaphragmatic breathing all day long. And while it's great, it's exactly what I teach patients to do. It's you're taking a step in the right direction, but you're also only doing half of the puzzle piece, or half of the puzzle with the breath work. There also has to be a pelvic floor involvement.
Hmm.
And if patients have, a lot of times, patients have no connection to their pelvic floor. They have no idea what's happening down there. They might be able to do the contraction, but whenever we go into the relaxation or the drop phase, patients are like, I can't feel anything happening down there. Like, I just don't know what's happening with that part of my body. And so sometimes I spend 2 or 3 sessions going over this with patients through various ways, different types of breathing techniques, different hands-on techniques. It's a huge part of what I do is getting patients to like connect with that part of their pelvic floor with their brain and learn how to gain control over it again. And so while knowing how to do a diaphragmatic breath is great, it's even better if patients have that intuition, that like mind body connection to be able to feel what's happening in their pelvic floor at the same time. And this, like I said, I don't want to undersell how hard this is for
Hmm.
a lot of people, especially whenever patients have chronic pain or they're dealing with erectile dysfunction or whatever other diagnosis. If this part of their body has been shut off for so long, it's really hard for people to wake it back up.
Hmm. Wow. Okay. So that's all really helpful and also super interesting. I'm wondering on, can you talk to the other end? So it's, to me, it's really striking how the issues go like one at one end or the other, right? You've got some people who are too active, and then you have people who are the not active enough. So do you want to talk more to the people who are not active enough, those people who are in their 50s and 60s and having, you know, having erectile dysfunction there? And I also want to just plant the seed. I also would like to talk about urinary incontinence, because I think that's something that I don't. I'm not. I'm not. I'm not. I'm not sure, but I think that talking about urinary incontinence would be even. You would, if you had to choose between two problems to talk about. I think I'd rather talk about erectile dysfunction versus urinary incontinence, right? Or I don't know what the
Yeah.
which has more shame behind it, so to speak.
Well,
I mean, that's a relative question,
I was
but
about to say that's a really hard question to answer. I
yeah.
mean, they're both patients that walk into the door with either dysfunction carry a lot of shame.
Hmm.
The reasons behind it are very different, though, and the ED patients, those. Let me. I'll break it down like this.
Let's
In
talk about. I asked too many questions at once.
That's okay.
Let's. Go ahead though.
Well, I
Keep
was
going
going to
with train of
say
thought.
incontinence is usually associated with some sort of post prostatectomy rehab, like
Okay.
patients that have gone through some sort of cancer treatment, whether that's a surgery, a removal, a radiation, chemo. Like usually it's cancer related, and the shame comes from the inability to maintain their dryness, and so they're going through pad after pad after pad and depends and diapers, and
Mm,
um, it's it lingers for months, and so there's this hygienic aspect of shame and this inability to control your body shame. But ED is not just limited to one diagnosis like most of the incontinence patients are. ED can be a result of, and I know you wanted to spend some time talking about the underactive demographic, but
hmm
ED can be a result of both parties, of both sides of the coin.
mm,
Um, if it's an underactive, usually it's it's there's a hormonal aspect to it. There could also be a cancer treatment aspect to it, especially the prostatectomy patients that have had their prostates removed. Like there's almost always some level of ED with that. Um, Also, just generally as men age, like I talked about the hormones, but just aging in general, the elasticity of the muscles, the weakness of the muscles, the elasticity of the blood vessels that maintain the erections. Like there's a lot of aspects that go into an underactive pelvic floor and the reason why they have ED.
hmm
Um, from an overactive standpoint, patients that have too much activity in their pelvic floor, the best way that I can give anyone to explain this phenomenon is what I call the clenched fist analogy. And I kind of want you to do this with me, Dean. So just take your fist and like squeeze it as hard as you can. Just like squeeze, squeeze, squeeze the hell out of it. And then now let go and take a look at your palm. Usually you'll see some like this influx, this flush of blood going back into your palm.
hmm
If you walk around your day to day life with a clenched fist in your pelvic floor, it's going to be really hard to get blood into that part of your body. The blood
mm,
vessels are so clamped off because of the muscles are so tense down there
hmm
that people just have a really difficult time even getting blood into the penis, let alone maintaining it in there. And
hmm
so, if people are walking around with an overactive pelvic floor for whatever reason, stress, surgery, a fall. Sometimes falls can impact the function of the pelvic floor. Um, from an overactive standpoint, ED can also be a symptom of that. And so the way that I treat it is completely different based on how people walk in the door. And it's really the only way that I can differentiate what category people fall into is by doing a pelvic exam. And
mm,
usually that entails an internal pelvic exam because the strength aspect of it, and what I mean by that is if somebody's coming into my office and I'm evaluating them and I'm doing their pelvic floor exam, I'm inserting a gloved finger into the rectum, and all I'm having them do is a pelvic floor contraction. I'm telling them, okay, now do what you think to be a kegel, or do what you think that it is to do a kegel.
hmm
Make your penis jump, make your penis shorter, try to hold in a fart. All of those cues are to engage the pelvic floor. And the
hmm
only way that I can tell what category people fall into is how well they're able to recruit the muscles to squeeze around my finger. If it's like a flicker of a contraction, in therapy, we grade strength on a 0 to 5 scale with pluses and minuses.
hmm
I always kind of say that 0 is like 0 out of 5 is you're dead. Everything's flaccid, completely just there's no tone at all. A
hmm
5 out of 5 is like you're squeezing the hell out of my finger, and not only squeezing it, you're pulling it up inside. On a 0 to 5 scale, if I'm evaluating somebody and checking their strength, however strong their contraction is, and it's all subjective too, right? So like
hmm
my scale, even though it's pretty standard 0 to 5, my subjective qualitative scale might be a little different than your subjective qualitative scale. And so inter inter-rater reliability is, the difference in measurements between two people and how they measure things. My scale might be a little different than yours, but
Mhm.
regardless, when I'm evaluating somebody, that's really the only, I don't want to say the only true method of categorizing somebody, but that's how I categorize them, is with that internal exam to check their strength. um, I forget why we were talking about ED and incontinence and categories, and
You
but
said a bunch of helpful stuff. I don't know how we got here, but
okay,
that's okay.
but we're here.
We're here. So I mean that kind of train of thought you just went on. To me, that leads to the question: can people, to what extent can people assess themselves, or are there other, you know, how can
The
people kind of? I mean, I'm not telling you to go home and stick your finger in your butt right now, but like, what are things that people can do to, are there things that men can do to kind of assess?
I would say the first thing, the most helpful thing that people could probably do is this diaphragmatic breath work that we were just talking about. Like, if you've already
Okay.
got a very detailed blog about, and videos and resources for it, what I would encourage people to do is, in the privacy of your own home, strip down to your birthday suit, work on this breathing, and place, two fingers underneath your testicles and just feel what your body's doing down there. If you take a breath in and you can feel the tissue kind of plump up into your fingers, well, then your pelvic floor is likely relaxing and doing what it's supposed to.
Hmm.
If patients, or if people are doing a diaphragmatic breath and they can feel the pelvic floor kind of squeeze and pull up and in, if it feels like it's tightening or retreating away from their fingers, well, they're likely contracting and they're doing the opposite of what it should be doing, which
Hmm.
to me is a hallmark sign that might be a little too overactive. And so that that movement of the pelvic floor is really the indicator of which side of the spectrum people fall on. And I wish there was an easy way for me to give you and your listeners of how to assess themselves. And I guess another way would be thinking of just subjective symptoms. Do patients, do they have pain? We haven't even really talked about the full scope of pelvic floor dysfunction and like what that really means.
Hmm.
But there are symptoms associated with it that sometimes people don't even know are symptoms, that they just like can assume are normal. Like, one of the most obvious, well, not most obvious, that's a incorrect wording. The people It's a symptom that a lot of people have that they don't even know that it's a problem, is something called post void dribbling. That's super common in men, where, we go to the bathroom, we stand at the toilet, we put our penis away, we walk to the sink, and a few more drops come out, or more than a few drops come out. That's something called post void dribbling. Unless it's like a drop or two, anything more than that, it can be an indicator of pelvic floor dysfunction, and usually it's an overactive pelvic floor. This is actually one of the reasons why I got into pelvic floor therapy, because this was a big problem for me. I was just finished was going through my last year of PT school, and one of the most stressful times of my life, that last semester. And I developed this problem, this post void dribbling problem, where I would take a piss, I'd walk away, and like, it was like a tablespoon of more urine that would come out. It would, like, to the point, towards the end of the semester, when I was like the most stressed I've ever been in my life, I would go to the bathroom and I'd walk out of the bathroom, and like, pee would have soaked not only my underwear but my outerwear too. Like, I couldn't wear khaki pants anymore because it was
Oh,
just
wow.
like so embarrassing. And so
Did you intuitively create that connection between your stress and the physical issue, or
I
did
didn't
you?
at the time. Once
Mm.
I started going through all this training, I was like, well, no shit. I have all of these pelvic floor issues because, I have never been that stressed in my life. But um, but yeah, so like I'm just going to run down the roster of some of the most common symptoms that patients come in with and
Hmm.
kind of put them into categories. So,
Yeah, if you could tell us which ones are, again, most people listing 50s, 60s, so like, or even 40s, 50s, 60s, 70s. So you could keep that in mind as you're going through the roster. I think that'd be helpful for everybody listening.
yeah, I'll start with an underactive pelvic floor. Um, the most common ones that we've already talked about: incontinence, or whether that's fecal incontinence or urinary incontinence, um, erectile dysfunction, and not just like it's difficult to get an erection, but also it's difficult to get and maintain an erection. Most common or most evident for underactive is the ability to maintain, or yeah, the ability to maintain an erection.
Hmm.
Um, Delayed ejaculation, somebody that just has a really hard time getting to the point of an orgasm.
Hmm.
Usually there's some form of hypotonicity or underactivity happening because their pelvic floor is not strong enough to get them to that threshold.
Hmm.
um, let's see. In terms of, we haven't really talked about much like bowel dysfunction, but
No, we haven't even gotten to that shitty territory yet.
Ba-dum-bum-tsh.
Sorry, had to
the
do it.
I would say the inability to hold back gas. People don't think that and it's not like a problem per se, but I have a lot of patients that are like, if there's gas down there, there's no stopping it. Like it's going to come out. And that can be really embarrassing for people. And so that is sometimes I would consider a sign of an underactive pelvic floor.
Hmm.
Um,
I find that working at home, I have very I have very undeveloped stopping your fart muscles because I just
I mean,
typically find myself in environments where I don't have to regulate.
there's a difference between allowing it to happen and not allowing, or not,
Yeah.
you know, if you're actually, like no one's around, I'm just going to like push one out real quick. Completely different than like walking out in the grocery store and just like inadvertently letting one rip. And you're like, holy shit, where'd that come from? um,
Yeah.
those, I would say those are probably the biggest like underactive symptoms. If I had to
Hmm.
rank them, ED, and then incontinence, and
Hmm.
then delayed ejaculation, and then we would put, flatulence issues
Hmm.
in there with that too. Um,
And are those, is there a not a generalization, but is there a correlation between I forgot what term you used, but under
under
activation, and the older population, or is
Yeah,
it is? Okay.
yeah. Usually the older population swings more towards the underactive pelvic floor, unless and this is, I've had patients like this, unless patients are 70, 75 that are avid cyclists, or that are, marathoners, or people that, outside of the typical demographic. Usually, as patients age, they tend to fall into the more of the underactive camp of
Hmm.
patients. The younger, more active, you know, patients tend to fall more into the overactive category.
Hmm.
Um, and with I know I heard you say that you wanted me to kind of keep the listener base and demographic in mind, but just to make sure that I'm covering the full spectrum.
Hmm.
Overactive pelvic floor patients, it's urgency, urinary frequency, pain with urination, waking up in the middle of the night more than, when we're talking about bladder norms, you shouldn't be waking up at all in the middle of the night. But if you do, like one is acceptable. Any more than one, like something's happening there that should
Hmm.
probably be looked at. Um,
Yeah, I think just to address this question specifically, I think there is, especially among the people that I email with and interact with through the Manful Yoga community, I think there is a big conception, and I would like to say misconception, that getting older just means, oh, these are issues that I now deal with because I'm older. And a lot of people, and they kind of just accept it. It's kind of like, oh, I'm in my 60s, so like now I wake up when I Now I wake up at night to pee, or like, oh, I'm in my 50s now. So, and I kind of hear that. I'm like, well, no, that's just because you're in your 60s doesn't mean you should be waking up 3 times per night to go pee. That
One of my
that's
f- one of my favorite, I didn't coin this, but one of my favorite like taglines, if you will, is common does not equal normal. Common does not mean it's normal. Just because
mm,
something is common and a lot of people experience it does not mean on a physiological level that it's normal. It shouldn't be happening.
mm-hmm,
And that, what you just described, waking up 3, 4, or 5 times a night to go to the bathroom,
mm-hmm,
is common as we age, but that doesn't mean that it's normal. And so that is something, absolutely something that pelvic PT can help with. I mean, movement in general, but
mm-hmm,
you're doing great work with Manflow Yoga, but there are a lot of commonalities that are not normal that can be addressed on a therapeutic level.
mm-hmm,
A lot of people just don't know about it, and that's the the shitty thing. A lot of people don't know that pelvic floor therapy is a thing.
mm-hmm.
What part of the reason why I started my TikTok page was to just get more awareness that men's health and men's pelvic floor therapy, like there are people out there that treat these things that
Yeah.
can help. Um, but just to continue going down the roster,
So
oh,
so
so go ahead.
and for all of these things, is pelvic floor strengthening the answer? Like for
No,
it's
no, no,
not.
no.
So what we just discussed, waking up at night to pee or to urinate, what is the what's the answer to help with that?
I mean, usually outside of lifestyle changes,
Mhm.
limiting fluid intake 2 hours before bedtime,
Mhm.
limiting any kind of bladder irritant. Um, Patients a lot of times have a, a impaired connection to their pelvic floor,
Mhm.
meaning that mind body awareness, and people live in this overactive state. And so, kind of the same thing. It's same principle, different kind of physiology of what happens, but that threshold the of getting to an ejaculation or orgasm, our bladder also has fill levels that send signals to the brain that tell us, there's something in here, we have to pee. There's like
Mhm.
4 different fill levels, and we don't know that it's happening. These are just subconscious cues that are being sent to our brain that are like, hey, you should probably start paying attention. You should probably go to the bathroom soon.
Mhm.
But when somebody lives in their day-to-day life with an overactive pelvic floor, the nerve endings, the little spidey senses in the bladder are hypersensitive, and so they're sending signals to the brain way before they should. And so a lot of times patients will say, I go to the bathroom and then I'll lay back down, and then 5, 10, 15, 20 minutes later I'll get another feeling of needing to go to the bathroom. Or, even an hour or 2 hours later, they'll wake up and it's like they'll go to the bathroom and a half a cup of urine will come out.
Mhm.
And it's like, well, what the hell? This shouldn't have like woken me up from a deep sleep when I just went to the bathroom. Like my bladder wasn't even full. And a lot of times, like I said, it's just all of that tension going into
Mhm.
the pelvic floor creates an upregulated nervous system. And if people are already upregulated from stress or,
Mhm.
anxiety or depression, everything, everything is just kind of, this is a kind of an extreme analogy, but like I always say, like your house is on fire. Like the signals are, everything is like sounding alarms all over the
Mhm.
place. Like your nervous system is just so excited right now, and not in a good way.
Mhm.
And so being able to get patients to quiet their nervous system to put out the fire through different, whether that's movement, whether that's breathing, whether that's meditation, mindfulness, like there are a
Mhm.
lot of ways to turn the dial down on somebody's nervous system.
Mhm.
But generally, for what I do, it's learning how to relax your pelvic floor,
Mhm.
getting flexibility into the pelvis and in the hips, and
Mhm.
getting you moving. Like I want to get you moving in a productive, therapeutic way.
So what are the exercise? What are the you mentioned? Prescribing basically yoga poses. What are let's just say like 5 poses you recommend to people to help relaxing pelvic floor.
I don't know what it's the yoga name for it. I call it a deep squat, but a supported deep squat. I think it's like
Oh, I don't speak Sanskrit. We didn't grow
Okay,
up speaking Sanskrit in my
good.
house, so,
Uh,
like, I don't know
it's a
about it.
supported deep squat.
Yeah. Okay, cool.
I have people up against a wall, down if their knees allow, will allow for it. I'll have patients they can use a yoga block under their butt, or
Yeah.
they can just use the wall to be fully supported. But
Mhm.
a fully supported deep squat,
Yeah.
um, where their hips are below their knees. Like people aren't doing wall sits. I'm not making them work their quads.
Yeah.
I want them, ass to the grass, knees spread, trying
Right.
to get a stretch into the pelvis.
Okay.
That's my favorite pelvic floor
Got it.
stretch
And
exercise.
just for people listening, because I know a lot of guys would not have the knees or the hip mobility to be able to even do that passively. So you can recreate that laying on your back right up against the wall with your feet pressing into the wall, and you can recreate that movement, and it might even be more relaxed. So
I My preferred modification, which that one's great, and I'm not trying to like step on anybody's toes. I love that one as well. If people, there are 1,000 ways to modify exercises.
mm.
If people can't do the supported deep squat, my next favorite modification is somebody on their hands and knees doing like a frog or like a child's pose.
Oh yeah.
Those are just using somebody's body weight combined with gravity is going to help open things up much more than somebody laying on their back. Like I'll give happy baby, like somebody laying on their back. If people are like, being in that child's pose position or that frog position just still really hurts my knees. Well, then my next go to is happy baby, like having somebody on their back with their legs up on the wall or just holding their
Hmm.
knees.
Yeah.
Um, my next favorite one is pigeon, but
Okay.
rather than having people do it on the ground, I'll have people do a standing pigeon with one leg kind of elevated on their bed or their couch
Yeah.
or some kind of surface because it just helps to open up all of the deep, deep hip rotators a lot more, in my opinion, a lot more than somebody being on the ground. If people either don't have a surface at home that they can't get their leg up that high, usually people have like a bathroom vanity or a kitchen counter or something that's like about hip height. But if they don't, um, the the floor pigeon pose is completely fine as
Hmm.
well, and does what I want it to as well. Um, really,
That's a good list of poses as far as I'm concerned. You don't have to force more if
well, I was gonna
there's.
say I have like six that I
Oh,
prescribe on a regular
okay.
basis for people, but they're not necessarily. That's why I was like kind of I was like, well, they're not really yoga poses. I guess you
That's
could.
I don't care if they're yoga poses
Okay.
specifically. If they're great stretches, great. Like, we do tons of non-yoga poses in manful yoga. So,
Yeah, like I said, I try to target the main muscle groups in the lower body and the hips with every patient that I get, every overactive patient that I get. And so, like a kneeling adductor stretch where you're on one knee's tucked underneath you, and one leg is extended out to the side. That's one of my favorite stretches. Um, a kneeling hamstring stretch, or even a seated hamstring stretch with one leg kind of extended out in front of you and kind of bending over and touching the toes. Um,
hmm.
a hip flexor stretch, just being, tall kneeling, one knee down. I like to add in a little bit of an overhead reach to get some of the lateral
Yeah.
abdominal wall muscles. People with testicular pain, this is a great one for one knee down, one knee up, just kind of reaching up towards the ceiling and doing a little bend to try to get all of the front of the pelvis and the lateral abdominal wall to stretch. Um, gosh, I like to do. There's 1,000 different names for it. I call it 90-90, just sitting on the ground with
That's
one
that's what
knee in
I'm doing right
front.
now.
Yeah, ninety
Hmm.
ninety is one of my favorites. That just yep. Depending on what people have going on, I'll have them do kind of a static position like you're doing, or a dynamic position where they're kind of windshield wipering their knees from side to side.
Yep.
Really helps to open up the hips. Those are probably, I would say, my top five prescribed exercises that I give people.
Got it. I mean, but the overall goal with all of these, it's all hip openings. I mean, that's
Literally
what it
opening up
is.
the hips. People, we live in a society where we sit all day long, and the hip flexors get tight, the glutes get shut off,
Hmm.
adductors and hamstrings get really tight. And so
For
all I'm
sure.
really trying to do is just open up the hips, get people to open up their pelvis.
Got it. So I don't want to spend too much more time on this portion, but what other common issues have we not already mentioned? And if we could mention them and maybe succinctly, because I do want to ask other
Yeah.
questions too.
Well, we haven't talked a lot about bowel dysfunction. And so I
Okay.
do think that it's important to kind of talk about some of those diagnoses. So,
Yeah.
constipation can be a function of pelvic floor dysfunction, hemorrhoids, fissures,
Hmm.
tears in the rectal canal can be a function of pelvic floor dysfunction. Any
Are
sort of
those are those things that can be are those things that can be helped with? 'Cause I always assumed that was genetic. Which now thinking back on my overall approach to everything health and wellness, genetics is not like the sole thing. So I'm wondering, yeah. So what does help with fissures and those things?
fissures,
Hmm.
just like I think of hemorrhoids and fissures in the same, they're not the same thing, but I put them in the same category.
Hmm.
And generally, it's when patients have too much tension in their pelvic floor. The anal sphincter is elastic. It has the ability to, just like every muscle, it has the ability to expand and extend. But if somebody is getting chronic hemorrhoids or chronic fissures, generally they've lost the elasticity of their anal sphincter. A lot of times is because people are clenching so tightly. They're walking around with an overactive pelvic floor.
Hmm.
And so patients don't know how to relax their pelvic floor. Have you seen those? I'm sure you know what I'm talking about, but those little, I don't know, when I was a kid, they had these little balls that you would squeeze and they're filled with, water, and you would squeeze it and it would like
Yeah.
kind of pocket out another like balloon or whatever.
Yeah.
Anyways, that same kind of thinking is what happens whenever we get a hemorrhoid. There's blood
Okay.
vessels in the anal sphincter, and whenever we're constantly squeezing and then we're bearing down and pushing to try to push something out, a couple different things are happening. Not only is there tension in the anal sphincter
Hmm.
and you're pushing on top of that to get poop out,
Hmm.
that is going to create a hemorrhoid. If you are constantly living in a clenched pelvic floor state, you don't know how to relax your pelvic floor, and say you have a bowel movement that's larger than normal, you, if the pelvic floor is clenched and you're in something
Hmm.
that is bigger than your sphincter is coming out of it, a lot of people will tear, and that's where fissures come from. Or if
Hmm.
you're somebody who engages in anal sex, if you're being penetrated and something, you have a large object going up there, sometimes that creates some fissures. um, then in terms of constipation, there's a condition called dysynergic defecation. Basically, the pelvic floor is supposed to relax whenever we defecate,
Hmm.
but people will reflexively contract whenever they're trying to defecate. And so it creates this functional
Hmm.
constipation where they they're doing that, their pelvic floor is doing the opposite of what it should.
So my kind of question here is the solution for this? Is it just training your body to relax? It's like it's the same thing we've been discussing. It's the breathing, it's the stretching, it's the um
All it sounds way too simplistic,
mhm,
because a lot of times it's not this simple. A lot of,
mhm,
like, that's why I have a job and a business, because
mhm,
I see people on a weekly regular basis. It A lot of what I do is just dampening down people's nervous systems, helping them to quiet their nervous system and to get their body to relax. um,
mhm,
it sounds easier than, or it's not that simple. Is what I'm
mhm.
trying to say.
Got
That's
it.
the solution, but it's not that simple. And
Yeah.
if the best thing for people to start that journey is to just get their bodies moving
Okay.
in a healthy way, and which is why I love what you're doing, because it like I said, it's a perfect marriage of what I do and what I want people to do.
That's awesome. Cool. That's great information. And by the way, just teasing this, but Lance and I have been discussing the potential of doing a program together. So if you think that's a good idea, please email me and let me know. Message me, however you message people. Um, and I hope it's something that we can do because I
I would
know that there
be
is.
super stoked for it. I think that would be a great idea.
I think it'd be awesome, and I think there's definitely a need for it. Um, so, anyways, are there any other problems? Like, I know there's more problems, but are there any other really big ones that we haven't mentioned yet?
there's a condition called hard flaccid out there that medically is not really recognized because it's more of a phenomenon than a medical issue.
Mhm.
But it's this feeling of always having an erection, even though you're flaccid, hence the name hard flaccid. Like your penis feels hard,
That's weird.
but you're flaccid. And it is really uncomfortable for people. And it creates this hypersensitivity. People will, a lot of times there's pain associated with it. That's a pretty common one that I see in the clinic. There's also a condition called Peyronie's disease, which this one is kind of genetic. It's not really a behavioral or a lifestyle condition. This is something where you get little calcified plaques in the shaft of your penis,
Mhm.
and it creates a curvature, almost an excessive or an extreme curvature. I have a guy right now who has like a 90-degree curvature up towards the ceiling. Like the last like inch, 2 inches of his penis like curves up towards the ceiling, or towards the head.
Wow.
Um, but yeah, that those plaques impair the penis's, the tissue of the penis to become, they cause it to become less elastic, and so it hardens and becomes a little fibrotic. And
Mhm.
so when patients get an erection, the penis will curve upwards. um, those are kind of too obscure. I don't want to say obscure, that's the wrong word, but
Mhm.
some of the less common but interesting diagnoses that I see as well.
Yeah. So I did also want to ask about I did want to ask about kind of the shame aspect of this and the, what, aside from this being a medical issue, in your opinion or your experience being in the field, to what extent is shame an issue with this and men not seeking treatment because it is, something to do with sexual function, or it could be something that, is associated with, I'm getting older and I don't want to admit this, or they're young and they don't want to admit it because they're young and they shouldn't have these, they don't think they should have these issues. So I'm just curious, in your experience, what are these factors at play?
No, yeah, no. There's a huge shame aspect to what I do and what I treat and the patients that come in. Um, there are some patients that are like, I don't care who helps me. I just want to get better, and so they're motivated. I want this to be gone. That's not. It's very unlikely that I get a patient like that. A lot of times, patients will put this off for weeks, months, years before they get it looked at because they're just like, it's annoying, it's bad, but I don't I don't want to have to do the thing. I don't want to have to admit it. I don't want to have to put in the work because it would mean actually having to ask for help. And by asking help, some people, realize that once they voice it out into the universe, then it actually becomes like a real problem. And
Mm,
so, when we're talking about ED, if all the doctors are saying, your hormone levels are fine, your blood work looks fine, we don't know why you can't get an erection. A lot of guys want an answer. And so I work very closely with sex therapists, mental health therapists that specialize in sexual health and intimacy.
mhm,
And, I always tell people, like, I feel like I'm pretty, I don't want to say confident, but competent in what I do and what I treat. I didn't go to school for the head stuff. I went to school for the physical stuff. And so I partner with a lot of sex therapists here in Atlanta to help with that kind of psychosocial aspect, the stress, the anxiety associated with their symptoms. And so
mhm.
whatever people are coming in for, if I sense that there is a lot of shame, if there is a lot of embarrassment, if there is a lot of anxiety, performance anxiety surrounding their issues, I
Or
almost,
trauma, past
or
trauma, right?
trauma, it's astonishing, even as men, how high, I don't want to say sexual assault is super common in men, but in my guys that have pelvic floor dysfunction, there a lot of times is a past history of some sort of trauma,
Hmm.
um, sexual trauma, trauma in general, death, any kind of loss can impact somebody's mental health, which can impact
Hmm.
their sexual health.
Yeah,
Um,
I meant sexual trauma, but yeah.
right. It's super super common, and so shame, trauma, loss, anxiety. Like I, while I have a cohort of sex therapists in the city that I work with, um, you know, I have to have a pretty full cup to do what I do. And I always tell my patients, like, we're going to become best friends by the end of this because I'm going to be asking a lot of very intimate, detailed questions about you. And while I understand that this is a very vulnerable place for you to be, it's information that I need to know in order to best treat you. And so I always kind of say, like, yes, I'm a physical therapist, but I'm a lowercase p capital T most days. And so
Mm,
there's a huge just there's a big emotional piece to what I do and creating space for people to be vulnerable in here.
yeah,
Um, but if people need more than what I can provide just in their 1 hour session, I usually tell them to partner with a sex therapist that I work
yeah.
with.
Well, this leads into a whole another list of questions that I will probably need to ask you at some other time. But really to get into the things that I'm thinking of, like to what extent do guys even know this is an issue, or like what are they coming in and thinking like I didn't even know that was a thing, and just making that adding that to the general conversation of men's health, because men's health is yes, it's prostate awareness, it is I'm just trying to think about like my Movember campaign, and
Right.
what they're and there's definitely a push now for mental wellness for men, and suicide prevention, in particular, and men's suicide rates being 5 times higher than women, um, and so there is a big push for mental wellness now. But I'm wondering, hopefully these other issues start to make it to the forefront, but we'll have to do that another time. And now I'm going to transition to my part two rapid fire, not so rapid fire questions.
Perfect.
And I've we spoke on the phone before this, and I kind of got to know you a little bit. And it sounds like you had you're in a lot of ways you're a traditional physical therapist with a focus on pelvic floor health, but you also started this TikTok to educate people, and it blew up, and now you're balancing how my you know so I guess I just wanted to mention that, in a sense to kind of prime where you might be coming from with your answers to these questions. um, so first question is, what do you think is one habit, belief, or a mindset that has helped you the most in terms of your overall happiness?
Oh gosh. Uh,
It can be anything. It doesn't have to be like the
listening.
most
Oh,
effective.
well,
It
I
can
was gonna
just be,
say listening to myself.
mm,
Like there's a
yeah.
lot of there are a lot of people that I love and respect that I look to them for answers
Mm-hmm.
when I'm trying to figure out what is the next best move to take.
Mm-hmm.
But a lot of times, like, I already know what I want to do. I just need to listen to myself and actually do it. And I sometimes I listen to too much advice from people when it comes to my own happiness.
Mm-hmm.
Like what's I just want, like, so a lot of times I work with my own mental health therapist, and I always say, I kind of joke with him. I'm like, I need you to be my like fairy godfather and be like, just tell me what the right answer is. And he's like, no, like you got to figure that out for yourself. So
Yeah.
I would say just listening to myself has really been consistently what has made me the happiest.
Yeah. And to clarify, listening to yourself in terms of actions you take.
Actions that I take.
Okay.
Yes.
What's one thing that you do for your health that you think is overlooked or undervalued by other people?
I spend a lot of time with myself. Just like,
That's so weird, dude. I was just thinking about that. Like I was literally asking myself the question in my head, thinking solitude, and you
yeah,
answered it.
yeah.
Weird.
I spend a lot of time with myself, and I am. am naturally an extrovert. I like being around people. I like giving my energy to people.
Mhm.
I thrive in community like situations and settings, but I also deeply cherish the times that I have by myself.
Mhm.
Like I am intentional about building in alone time throughout my week just so that I have that time to recharge.
What's that look like for you?
I mean, my clinic is right next door to the park, and I think I even took a phone call with you. Our last my
Yeah.
last call, I was in the park, and going to the park when it's a beautiful day outside is one of my favorite things. Just I have
Mhm.
a hammock that I'll set up between two trees, and like that is my like I love that. I live for that. Just setting up, just chilling in my hammock, just relaxing is my me time.
Nice. Okay. Yeah, that's a great way to do it. What is the most important activity you regularly do for your overall stress management?
Oh gosh, if I don't go to the gym, I can be a real asshole. Like,
Mhm.
I'm not a real asshole. I'm nice, but I go a little crazy in my brain. Like the
Mhm.
gym, lifting heavy things and putting them back down again quickly is my form of cardio, and
Mhm.
like that
That counts as far
the
as I'm concerned.
yeah, the gym is my safe space. That's where I go to just like let it all out.
Mhm. Nice. I can sympathize with that. What's the most stressful part of your day-to-day life?
Oh gosh, I I love my job, but probably running my clinic,
Mm.
managing patient care, and also running the business at the same time is it, there. I have an administrative assistant that helps me, but she can only do so much when it comes to direct patient care, and so
Mm.
um, managing a full caseload while running and growing a business is definitely the hardest stressful part of my day.
Mhm. What do you think is the biggest challenge facing men and their well-being?
Toxic masculinity, the idea of what a man is supposed to be,
Mhm.
and what they can and what they are and are not allowed to be and do. Vulnerability is really hard for a lot of guys, and
Mhm.
shame is really hard for people to deal with, men to deal with. And
Mhm.
so I would say this like toxic masculinity world that we live in,
Mhm.
this paternalistic world is probably the hardest part.
Got it. To me, it sounds like your use of toxic masculinity here refers to not just like it being imposed on you, but also just the effect that its purveyance in general society has on your internal, guidance of how you think and behave.
Yeah. I I mean, I live my life. I'm, openly, proudly out and gay, and a lot of my caseload, a lot of my patients are also somewhere on the LGBTQ, alphabet spectrum.
Mhm.
And in building my business, I was very intentional about building it around these two identities of being gay and also being a man because of
Mhm.
what we just talked about of it being difficult for men to be vulnerable and experience shame and deal with these very sensitive issues. As a man, I fully understand that. And so I wanted to grow my brand and my business and be able to talk and speak to any man, anybody that identifies as a man, but also anybody that identifies as gay, because this just outwardly and world that we live in, there are a lot of nuances and a lot of ways in which men are told how they're supposed to act and what they're supposed to do and how they're supposed to behave, and
Mhm.
it it can really affect people's mental health whenever you don't fall into that, you don't fit into that mold,
Yeah.
or you do something different that is goes against that ideology. And so
Mhm.
um, when I say toxic masculinity, it comes from those two viewpoints.
Mhm. Yeah, that like the man is supposed to behave this way, and if you are not behaving this way, then you're wrong. Yeah.
Yep.
And that's that's regardless of where you are in the sexual spectrum. That
Right.
is like, right. That's like,
Yep.
I think that's we get that variation of that answer a lot,
Yeah.
in the sense of, yeah, like there's so many things telling us how to behave and what to do that we are neglecting, or we are deliberately hurting our mental, emotional, physical well-being because we're listening to them instead of like doing what we feel is aligned with ourselves.
Right.
So, um, cool. All right. Well, Lance, thanks for joining me today. By the way, you guys should all go follow Lance on Instagram and TikTok. It's Lance in your pants, right?
Yes. Yes, it is.
Okay.
TikTok and Instagram, Lance in your pants. That's my username.
And it is very accurate. So that makes sense. And yeah, hopefully, Manful Yoga, Lance in your pants, pelvic floor health program coming soon. So stay tuned on that. It is something that I wanna do, and I think it'd be really cool. So um, yeah, I think this is really great. I got a lot of my own personal questions answered. I think there's even more. If you listen to this and you didn't get one of your questions answered, I would love an excuse to have Lance back on the podcast. So
For sure.
send me those questions if you're listening and you're like, hey, I had a question about this, and let's get it answered. So yeah, thanks again for joining me today, and
Thanks
I
for
will
having me.
yeah, I'll look forward to working more with you in the future.
Perfect.
All
Look
right.
forward to it.
Thanks, guys, for tuning in. I'll see you guys on the next episode of the Better Man Podcast. If you like that episode, check out this other one right here. I think you're really going to enjoy it. If you haven't subscribed, click this subscribe button over here, and you can listen to the full episodes on any major podcasting platform. Full details below in the description.